Good afternoon, colleagues. Welcome to our afternoon session in Jacaranda 123. The session we are going through is titled Improving Data Utilization to Better Address Stigma and Discrimination, Fixing the Gap of Financial Resources, Policies, Strategies, and Ownership. So in terms of our panelists, we have those who speak in English and those who speak in French. So those who would want to hear the translation, you can get these headphones, these gadgets for the translations from English to French. And when French speakers are speaking, I'm told the translator in the box would translate directly to the audience from that end. So for the translation from French to English, we might not need this. The translator will handle that for us. Okay. We can start, and the first is to introduce our panelists to you. On my immediate left, that's Augustine Dokler, who is the president of the Network of Associations of People Living with HIV in Togo, and is very much experienced in advocacy and capacity and community building. And he has a long history in working for civil societies in Togo, particularly in HIV and AIDS and the West African region, as well as at global level. And then on my immediate right is Pim Luz, who is the People Living with HIV Stigma Index Senior Program Officer with Global Network of People Living with HIV. She's a passionate young person in terms of HIV-related stigma and discrimination. And she has been an activist since the age of 12, where she was working with a mother who is living with HIV and also a founder of International Community of Women Living with HIV. And Pim holds a master's in child development from Amsterdam University in the Netherlands, her hometown where she is based. And she coordinates the implementation of the stigma index research by networks of people living with HIV globally, and also support some country networks when they are implementing the study. So welcome, Pim. And then to my far right is Ibrahima, who is the director of Bok Yaka Association in Senegal. And he has over 15 years experience in HIV and AIDS. And they have conducted quite a number of stigma indexes in Senegal, and has been an advocacy in response to HIV, particularly focusing on new treatment regimens, which are more effective for people living with HIV. And his activism started way back in 2006, and is the Secretary General of National Networks of Associations of People Living with HIV in Senegal. And he has also been influential in strengthening the JIPA principle in his country. So welcome, Ibrahim. Okay. So just to give setting the tone for this session, we are going to hear the experiences of various players in terms of HIV and AIDS Stigma Index Study 2.0. And to kick us off, I will pose a question to Pim Luz, whom I said is the People Living with HIV Stigma Index Senior Program Officer with Global Network of People Living with HIV. So to you, Pim, in 2020, a standard methodology was introduced for all people living with HIV stigma index implementation in order to launch uniformity across countries for comparisons. So there's been this trend of development of global and regional reports by the networks of people living with HIV. So is there also a standard methodology that needs to be followed in developing a regional report on stigma index?
Thank you so much, Tandurai. And that's absolutely right. So in 2020, we've launched a standardized methodology for all stigma index studies to follow. But the stigma index has been around since 2008. But before that, there was the same tool, so a standardized questionnaire, but not a standardized methodology. So what you get is, even though people are using the same instrument, we saw completely different methodologies. We saw sampling in only very specific venues. We saw some with very large or very small sample sizes. There were just various huge differences between the implementations that made it very difficult to compare the findings between the different studies. So when we launched the standardized methodology, the aim is really to increase the comparability between all these stigma index studies over the world, over time, and also across different settings. So now there are guidelines that every stigma index study has to follow in terms of the geographical scope of the study, how the sample size is calculated, what is the target population to be included in the sample, and also the sampling strategies that must be used. So now that we have this, we are, let's say, finally able to, with a strong basis, really develop regional reports and even a global report. So that's been really exciting, and it can be very useful to have regional reports to really see what are some of the key similarities or differences between countries. And maybe we can also have a more strategic approach at regional level in addressing stigma and discrimination. So with that said, yes, we are developing a regional report methodology, which is very different than a standardized methodology, because with regional reports, the data has already been collected. So it's really more about the process of developing the regional report and not so much about how the data is collected, because that part is done. The hard work is done. So what's really important for these regional reports is that all the studies at national level have used the 2.0 version of the stigma index tool, have used the standardized methodology, and are implemented within a time frame of 5 years, so that the data is still to a certain level of recency, let's say. So we've actually done the first regional report in West Africa region, where Augustine was involved as well, which included 7 countries: Togo, Benin, Burkina Faso, Mauritania, Cote d'Ivoire, Ghana, and Nigeria. And it was led by the regional network of people living with HIV. So even for regional reports, they must be developed with the same principles as all stigma index studies at national level. The leadership of these, the development of these reports must always be at people living with HIV. So the regional network has led the development of the regional report, but in close consultation with the national networks of people living with HIV, who have led the implementation in their respective countries. So what's really important here is that there's a strong collaboration between everyone involved in the implementations at country level and then the regional networks. So what we've done for the West Africa regional report is there was a large consultation process, or even a workshop, I can say, last year, April, in Senegal, where we brought together representatives from the regional networks and the national networks from these 7 countries. And we sat together and we really thought through the regional context and what are the priority issues in the region. And based on that, we went through the tool and we selected the key questions from the questionnaire that we thought would be important to include in this regional report. So then we came out with a list of the key questions that we wanted to report on. Then we went one step further and we started thinking through the levels of disaggregation. So if we look at this question, how do we want to look at this? Do we think it's important to disaggregate the findings by age? by country, by gender, by key population, etc. So we've really thought it through, and basically what you do then, you develop your data analysis plan with that. Then we get to a few more practical steps. The data needs to be cleaned in a uniform manner so that we can merge all the data sets, and then we can run the analysis and write the report. But then we get to another crucial step where we really need that consultation process, and we need to consult with the national networks on, okay, if these are the results, what are then our recommendations? And how would we realize those in the region, but also in your country specifically, so that we can really follow up with evidence-based advocacy. So that was our first experience in doing a regional report with only countries who had conducted the stigma index using the standardized methodology.
Thank you very much, Pim, for sharing your experiences in terms of implementation of the standard methodology. And now to you, Augustine. Togo was part of the regional network, of the regional report that was developed by GNP Plus and other regional networks. Can you tell us what was the role of the national network in terms of development of that regional report? And then if you can briefly share some of the findings from that regional report. Over to you.
Merci. Merci pour la possibilité qui m'est offerte pour nous exprimer sur cet important rapport et cette importante démarche. Lorsque nous parlons de la stigmatisation, de la discrimination, ce ne sont pas des chiffres que vous avez, ce ne sont pas des données que vous avez, mais ce sont des véritables drames qui se produisent sur l'humanité, notamment sur les communautés les plus touchées, les personnes vivant avec le VIH et les populations clés.
Okay.
Et notre seconde expérience par rapport à l'élaboration de ce rapport nous a été très enrichissante et nous étions partis Ça peut aller?
Oui, on y va.
OK. Et cette expérience nous a quand même permis de pouvoir utiliser le document que l'Alliance internationale ou le GNP Plus a proposé pour faire ce travail, et ça nous a permis aussi de...
Allô?
Yes, sir. Thank you. Je vais être très, très concis, précis pour que vous puissiez restituer aux gens.
Ok, merci.
Bien. Et alors, notre expérience par rapport à ce index stigma, quand même, ça a été très, très enrichissant, et ça a permis au Togo de pouvoir élaborer son deuxième rapport sur l'index stigma 2.0.
Yeah, our experience using index stigma was very important, and it has helped Togo to elaborate and report on that.
Et cette expérience également a été conduite de bout en bout par le réseau des personnes vivant avec le VIH, avec l'appui d'un certain nombre de partenaires, notamment le CNLS, le NAC et l'ONU-SIDA.
And this was done with the help of UNAIDS and support from other agencies that has helped us.
Alors, cette expérience, nous sommes partis de cette expérience pour avoir notre second rapport sur les index stigma qui nous a permis d'avoir un certain nombre de faits réels sur ce que nous avons fait par rapport à l'index stigma en termes de conduite, en termes de recrutement des participants et en termes des enquêteurs ou les personnes vivant avec le VIH. Et les populations clés touchées par le VIH ont conduit de bout en bout ce processus.
So it helped us to find out more about people who were living with HIV and to find out their data on how to help them out.
Alors, cette expérience, au vu des différents rapports, nous avons eu la chance aussi de pouvoir participer à l'élaboration de rapports régionaux et qui nous a permis de sortir un certain nombre de recommandations pour pouvoir aider l'Afrique à bouter dehors la stigmatisation, la discrimination.
And it helped us to also come out with some some dish of how to help Africa to come out from these stigmatizations.
Alors, les différentes recommandations sorties de ce rapport nous permettent également de voir comment est-ce que nous pouvons soutenir sur le plan financier, sur le plan technique, les organisations de la société civile, notamment les réseaux des personnes vivant avec le VIH, à pouvoir financer la lutte contre la stigmatisation et la discrimination au niveau de chaque pays.
The recommendation also these societies and to help them to come out with means for them to speak and to.
Alors, comment ça nous a permis aussi de ressortir une autre recommandation, comment est-ce que nous pouvons élaborer un certain nombre d'outils que nous devons disponibiliser pour les différents acteurs, notamment les programmes nationaux et même les institutions juridiques également, à pouvoir prendre à bras le corps le problème de la stigmatisation et de la discrimination.
Also to bring the tools on how to bring those staff, and then they can also help in our communities.
Alors, en substance, c'est une expérience assez importante et nous pensons que ça nous a permis aujourd'hui de disponibiliser des données au niveau national pour la prise de décision allant à l'éradication de la stigmatisation, la discrimination et les violences basées sur le genre.
And it helped us to have some data on gender-based violence and different factors that will help us.
Alors, je vous remercie par rapport à cette première question et je vais revenir. Merci.
So I thank you for this first question, and I will come back to you. I thank you.
Okay. Thank you very much, Augustine, for sharing your experience in Togo. And now over to you, Ibrahim. Can you share with us from the Senegal experience? You have implemented quite a number of stigma indexes in Senegal. So how have you been using the data for advocacy?
Si vous pouvez partager avec nous l'expérience sénégalaise, comment vous utilisez l'index stigma et la mise en œuvre, comment cela se passe au Sénégal.
Okay. Merci, monsieur le modérateur. Merci également
Thank you, Mr. Moderator.
à
Thank
tous
you.
ceux qui sont dans la salle.
And everyone present in the hall.
Juste pour dire que le rapport index et stigma fait partie l'étude index stigma fait partie des études où le rapport a énormément de données à exploiter. Il suffit de voir comment cette étude-là elle est conduite dans nos pays et quelles sont les informations qu'on peut recueillir à travers cette étude-là pour pouvoir vraiment en faire un outil de plaidoyer efficace.
So we have to see how that study had been done in our country in order for us to get some advocacy and go through it well in an effective manner.
En prenant le contexte du Sénégal, nous avons mené l'étude en 2012-2013 et nous l'avons refait également en 2017.
In Senegal, we did it in 2012 and 2018, and we did it again in 2017.
Et le rapport nous a permis de mener plusieurs actions de plaidoyer. Les données nous ont permis vraiment de faire des actions concrètes au niveau national.
And these data helped us to make some concrete actions in the national level and also have some advocacy.
D'abord, il faut noter qu'au niveau du réseau national des associations de personnes vivant avec le VIH, on avait choisi 4 grands points de ce rapport-là pour vraiment les utiliser comme des outils de plaidoyer.
So we use 4 key points on the national network to use it for advocacy.
D'abord au niveau de la population générale, parce que le rapport avait démontré qu'au niveau du Sénégal, le taux de stigmatisation avoisinait les 45% au niveau de la population. Et donc, du coup, on a pu utiliser ces données-là pour mener des actions de plaidoyer auprès des autorités administratives, des autorités médicales, des autorités religieuses et des autorités locales pour pouvoir essayer d'inverser cette tendance-là, essayer de réduire la stigmatisation au niveau de la population. Donc, on a fait l'ensemble des 45 départements du Sénégal pour organiser des journées de plaidoyer au niveau des leaders locaux.
So we did about 45
départements.
45 departments, and then it helped us in Senegal, and we reached different government departments.
Alors, l'étude avait démontré aussi qu'il y avait de la stigmatisation en milieu sanitaire, ce que au début on ne voulait pas croire, mais l'étude a démontré qu'il y avait de la stigmatisation aussi bien au niveau de l'entrée, mais au niveau des services de maternité également. Et donc, on a pu également mener des actions de plaidoyer auprès des chefs de service médical, mais également au niveau des services de maternité pour réduire la stigmatisation au niveau des femmes enceintes séropositives.
Okay, the study showed that there was stigmatization in the health sector and also in places like maternities and clinics, and we tried to also reduce that.
Ce qui était important aussi, c'est que l'étude index et stigma avait démontré qu'on avait 70% d'autostigmatisation. Et ça également, ça nous a marqué, et d'où plusieurs interventions qu'on a eu à mener également au niveau des associations des personnes vivant avec le VIH.
And it shows that also there was about 70% of auto-stigmatization among people who were living with HIV.
Et donc, on a pu organiser des activités de prévention positive, de santé positive, dignité, prévention auprès des personnes vivant avec le VIH pour renforcer l'estime de soi, renforcer la confiance en soi pour que l'autostigmatisation puisse être également réduite au niveau de cette population.
And then we did some training with them so that they can have self-esteem and to eradicate that auto-stigmatization.
Et l'étude également nous a permis de voir qu'il y avait une double stigmatisation également au niveau des populations clés. Parce qu'on s'est rendu compte qu'au niveau des hommes qui ont des rapports sexuels avec d'autres hommes, on était presque à 100% de double stigmatisation. Et au niveau des professionnels du sexe, à 80%. D'où l'importance, le réseau avait organisé une assemblée générale pour ouvrir un poste dans le conseil d'administration pour intégrer les populations clés dans le conseil d'administration du réseau.
Ok, là vous êtes un peu trop rapide. Ok, point par point.
Ok, donc je disais que aussi l'étude a démontré qu'il y avait une double stigmatisation chez les
There was
populations.
a double stigmatization according to the studies, the research which had been done.
Et donc la stigmatisation était à 100% double chez les MSM, les hommes qui ont des rapports sexuels avec les hommes.
So men who had sex with men, the stigmatization was at 100%.
80% c'est les professionnels du sexe.
80% for sex workers.
Et donc, on a pu, à partir de ces données-là, on est parti à l'Assemblée générale
We went to
et
the
on
General
a intégré
Assembly
les
and
populations clés dans le conseil
integrated
d'administration
the key population
pour qu'ils puissent avoir une voix également
for them to have a voice
dans la lutte contre l'autostigmatisation
in
au
the
milieu.
fight against auto-stigmatization.
Deux derniers points maintenant pour ne pas être trop long, c'est que
Two other points to be
l'étude nous
brief.
a permis au Sénégal pour la première fois d'organiser une marche avec les personnes vivant avec le VIH pour vraiment réclamer la réduction de la stigmatisation dans le pays.
And this study allowed us to do a match in Senegal with people living with HIV and AIDS to reduce the stigmatization.
Et grâce à l'étude également,
And
les
because
données
of
ont
this
pu être utilisées dans
study,
les notes conceptuelles au niveau national.
We
Le
can
programme
use this-
national a pu puiser des données dans l'étude pour pouvoir vraiment alimenter la note conceptuelle dans le cadre du financement du Fonds mondial. Thank you.
Thank you very much, Ibrahima, for sharing with us your experience in Senegal. And maybe briefly to you, Augustine, how about in Togo? How did you use the data for advocacy? I'll give you 2 minutes.
Comment avez-vous utilisé les données de plaidoirie au Togo?
Ok, merci beaucoup. Et comme nous l'avons dit, le rapport togolais quand même est de très bonne qualité et qui nous a sorti, qui a fait des analyses extrêmement fines.
Yes, the Togolese report is very good and did some great analysis.
Alors, ça nous a rapidement permis de convaincre le Conseil national de lutte contre le sida d'élaborer un document.
It allowed us to convince the National AIDS Council to elaborate a document.
Et sur les questions de droits humains, violences basées sur le genre pour 5 ans.
And human rights issues and gender-based violence issues
Et c'est
for
un,
a time frame of 5 years.
et c'est un document qui est assorti d'un budget.
Deux sujets.
D'un budget.
Deux
budget.
budgets. Oh, and
Budget.
it brought out 2 budgets.
Et la seconde chose, ce document nous a permis également de mobiliser d'autres ressources au niveau de PEPFAR pour les actions de lutte contre la stigmatisation et la discrimination.
And it also allowed us to mobilize other resources from
PEPFAR,
yes.
PEPFAR, ok.
PEPFAR, yes.
Alors, et nous avons utilisé ce rapport également, nous avons utilisé cette donnée pour étayer les argumentaires sur l'élaboration de GC7.
Also use those data to bring up some arguments on the G7.
GC7, yes.
Yeah, G7.
Yeah. Et ça nous a permis également d'avoir des activités et nous pensons que ce sont des données assez bien élaborées et qui sont assez claires et qui ont enclenché des sensibilisations au niveau d'un certain nombre d'acteurs.
And it helped us, and we think that those data is very important for the sensitization.
Notamment les personnes, ceux qui travaillent dans le milieu de soins,
For people who are healthy, working in healthcare,
ceux qui sont en milieu communautaire et les leaders religieux et coutumiers,
and also those who are in the religious sector and traditional.
Alors, bref, pour résumer, ces données nous ont permis d'avoir toutes les portes ouvertes auprès des différents partenaires pour mobiliser pas mal de ressources pour la lutte contre la stigmatisation. Je vous remercie.
Those data help us to go and get some funds from different partners to fight against stigmatization. I thank you.
Okay, thank you very much, Augustine, for sharing with us your experience in Togo. And so on my far left is Reverend Professor Gideon, the founder of International Network of Religious Leaders Living with HIV and AIDS. So Reverend Kenon, can you share with us in terms of the faith communities, how you are working on stigma and discrimination? Over to you.
Thank you very much. As you have heard, Canon Professor Gideon are my names. That's it. I am the founder of the International Network of Religious Leaders Living with or personally affected by HIV. We are 40,000 members in 25 countries. 16 country networks are active. And I come from Uganda, the first religious leader to publicly disclose my HIV status in 1992. We upload the stigma data and especially the tools that are available to help us fight stigma. It has helped us a lot because when you present evidence, it is the faith leaders listen attentively. For example, right now in Uganda, we have two challenges. The challenge of 200,000 people who are positive but do not know they are positive, and 80,000 people who are positive, they are on medication, but they are not adhering well. Now, the interesting thing which data presented was the area that has the 200,000 is the same area that has the 80,000. And when we showed it the religious leaders to see, look, it is not the absence of services because that belt is really heavily funded. It's within the cities and so forth. And we showed, look, the problem is not absence of service. It is that people are not accessing the available services because of the stigma. And that sunk. But because of time, I will go to the three gaps that we could improve in our data. One is that we still don't have indicators to measure the stigma from theology. The theology influences the ethics. The theology and the ethics influence the spirituality. And the three influence the legislation we have in the communities that are very religious. So unless we see where the stigma is within the theology, within the music, the worship services, the sermons, we may not be able to decriminalize the laws that are targeting people who need services most, but are accessing them least. The second gap I see is that some of the messages we send to prevent HIV are the very source of stigma. And I wish this audience and others can work out on that. When you say abstain, be faithful, if you can't abstain and you can't be faithful, use condoms. Then when Gideon goes to the shop to say, give me 3 packets of condoms there, you really see someone flabbergasted. You know, sin has gone too far. Even priests are asking condoms, you know, because they have been told that condoms are used for those who can't abstain and those who can't be faithful. So we need to really change that to say faithfulness and safeness are different things. Drinking your own water does not necessarily make it safe. You have to drink your water, but also boil it. You must sleep in your bed, but also put a mosquito net. The last point I want to make, Mr. Moderator, is the stigma that is coming from the data, the way we present data. I have been in 3 settings where people are presenting the data to religious leaders, and they have a pointer, and they are saying, religious leaders, we need your help. Look, the highest prevalence is among men having sex with men. The second highest is sex workers. The third is injecting drug users. We need your help. And the religious leaders, instead of engaging with the data, they tell the presenter, we have always told you, these people, unless they repent, unless they change, they are going to die. You know, even that data you have presented is not strong enough. We we want them dead. Probably what the data could improve would be to say, wait a minute, that is what the science is saying. But what do the three have in common? Number one, all the three do not get information that is adequate and timely. So the data should be presenting on that. Number two, all the three do not get an adequate supportive environment, whether it's in the family or it's in the community or it's in the legislation. So there should be data talking about the difference between those who access love in those areas and those who don't. Like me now, you see 32 years with the virus, very healthy, zero transmission, zero stigma, zero death. Why? Because I have been loved, cared for, and supported. So there should be data saying, let's compare those who have been loved, cared for, and supported, and we compare the mortality and the morbidity of those who have not been loved and supported and cared for. There we could make a step forward. But the way the science is prevented, the religious leaders switch off, others vindicate themselves and say, oh, you see, we told you. Yet, if they are challenged that the three are people who need love